So I welcome you all for this 27th episode of the Kaksha series. The Kaksha series was started about a couple of years back, and it has had a good response from most of the postgraduates and young ophthalmologists. So the format here is we have a master who is the expert in the particular field. So today we have Dr. Siddharth Dikshit with us. He is a glaucoma consultant and a prolific glaucoma surgeon and expert at LVPI Hyderabad. So he'll be talking about optic disc evaluation and its correlation with the OCT, which is a very important part to understand glaucoma and its optic neuropathy. So we have Dr. Siddharth here with us. And at the same time, we also have two residents, Dr. Simran, she's joined us now. So Dr. Simran and Dr. Ankit. So they are going to be on the hot seat and they can stop Dr. Siddharth and ask for some clarification in case they feel that this particular point has not been clarified. The idea of this series is to make the residents understand the intricacies of diagnostics or surgical or the disease process. So it's an elaborate, a long class. We have about an hour or so for disc evaluation. So that's it. So over to you, Dr. Siddharth, and the floor is yours now.
Thank you so much, Dr. Ankur, and to the Rajasthan Ophthalmic Society. I am talking to the group that I love the most, the residents. And as you can see, our heads are shining. And I'm quite sure it is the same that is true for your careers, or your careers are about to shine. And you are the ones who hold the future of ophthalmology in this country. And as a glaucoma specialist, I must tell you that the load of glaucoma is the highest amongst all the countries in India, and we cannot carry this burden alone. Everyone who wants to be a glaucoma specialist, I love you the most, but everyone who is not going to be a glaucoma specialist, I demand the most from you. You cannot be sending a patient for applanation to someone else. You cannot be sending a patient to someone else for gonioscopy or for disc assessment. And that is where my role comes in. And pardon me if I misunderstood the intention of the talk today, but I had assumed that we are going to be talking about correlation more and OCT more. Ankit and Simran,
Yes, sir.
in your experience, what year of post-graduation are you in, Ankit?
Sir, we are currently third year residents, sir.
Oh, wow. You are as good as me then. Right. So what is the commonest investigation printout that glaucoma patients carry with them when they come to you?
Sir, they carry out mostly OCT printout and some perimetry.
Right. And that is a sad reality. That is a sad reality. And before starting, I must again thank Rajasthan Ophthalmic Society and Dr. Ankur and Dr. Pratinya, who was a fellow and has played a part in forming the basics of this presentation, that out of the holy trinity of glaucoma diagnosis, that is disc evaluation, visual fields, and the OCT, can you answer what is the most important thing that clinicians look at when they are trying to diagnose glaucoma?
Sir, optic nerve, basically the optic nerve on the fundus examination.
Okay. Simran, what is it that people do in your experience?
Sir, I think optic disc evaluation is the primary thing because most of the places we do not have OCT. So primarily they go for it. And
so let me reframe my question. You have seen enough patients in your college coming for glaucoma evaluation from somewhere else. And what is it, do you think, that people pay attention to when they are calling a patient as a glaucoma suspect or someone who needs greater evaluation for glaucoma?
They mainly look for the retinal nerve fiber layer in the OCT examinations, what we have observed.
And that is why we have this class today, because you need to look beyond the
Yes,
OCT. And as you said, you don't have that easy an access to OCT, but still a greater access than visual fields, which is an isolated, expensive instrument purely dedicated to glaucoma. Whereas with OCT, you can just diagnose macular edema and keep injecting anti-VEGFs and earn money. That's what it has come to. Ankit, what
Yes,
is
sir.
it in your experience that you think that people pay most attention to?
Sir, I think IOP, because
Absolutely. This is really the bang on thing. And it is unfortunate because around 30% of patients who have glaucoma will not have raised IOP at the first examination, as well as the fact that 30% of patients who have intraocular pressures greater than 21 are not going to have glaucoma. But that is what our driving point is. I will repeat what my mentor has said, Dr. G. Chandrasekhar, and I will reiterate that every time you look at the disc, you have to assume that this is glaucoma, and your responsibility is to prove that this is not glaucoma. Every time you look at the cornea, you have to assume that this cornea has either an infection or an ectasia, and then look carefully and rule out both. Only then will you be able to force yourself to examine every aspect of the cornea, lens, retina, optic disc, the peripheral retina to the maximum extent, and then be a comprehensive ophthalmologist. Right? So I start with a gyan, but that is what I'm supposed to do here, right? So I was a little mistaken here. I'm saying sorry to Dr. Ankur, because I have primarily invested in interpretation of OCT and then the correlation with the optic disc. So that is what my PowerPoint is, and that is what I'll have to focus upon, the correlation. But I will keep coming back to the visual fields also. And I have absolutely deliberately kept out the intraocular pressure out of question. Because when you see a disc like what you see here, when you see a visual fields like what you see here, and you see an OCT like what you see here, irrespective of the intraocular pressure, you have to have the capability of diagnosing this optic disc as glaucoma, no matter what else is in store. So, as I said, I'll be looking at primarily just introducing a little bit about OCT because that's very important. A few things. Interpreting the OCT printout, it's important for exams, but it's much more important in your primary life. Exams is going to be probably important for 1 month, 3 months, or 6 months. Your life as an ophthalmologist is probably 60 years. So let's concentrate on that and try to correlate it with the disc and try to correlate it with what lies beyond the disc. Now, why has imaging become so important? It has become important for a theoretical concept that 25 to 35 and sometimes even 40% of ganglion cell loss could have occurred before you can see an obvious change in the visual fields. That's not entirely true, but it's a semi-true. So there is significant amount of ganglion cell loss that could have occurred, which basically means glaucomatous damage could have occurred before you start seeing a visual field change. And the practical reality is, as Ankit mentioned, and I'm sure Simran will also experience, that a lot of patients who are suspected to have glaucoma or have glaucoma are going to come to you with an OCT printout. That just makes more financial sense. Ankit, a small question for you. Do you know about the SciPass implant? No? Simran? Okay. The SciPass implant was the most promising implant a few years back in glaucoma as far as MIGS is concerned. And then in 2019, it was bought by a particular company. And just a year later, it was reported that the implant has significant endothelial cell loss. And then the company voluntarily withdrew that implant from the market. What is prevailing here, the science or the economics? A company buying a product a year back and withdrawing it a year back without any pressure on it being that suggests that it was being forced to do so, it withdrew it. So there is economics that works, and that is why you're going to see much more OCTs, many more OCTs than visual fields for patients with glaucoma. Now, across the spectrum, you have these many OCT devices available for assessing the macula, and along with the macula, the optic disc, RNFL, and everybody has a macular program also. What one has to remember here, that you cannot extrapolate the numerical measurements from cirrus to RT-view, from RT-view to spectralis, from spectralis to topcon, and these will all remain isolated. Any person who has bought, say, spectralis, we never have had spectralis for glaucoma measurements, but somebody who has had spectralis can never move away from it, because the measurements on spectralis can't be extrapolated to that of the other devices. So you will see the influence of a company which produces large-scale diagnostic equipments across specialties to dominate. And that is why cirrus is what is most dominant, cirrus is what is most popular, and cirrus is what we have. What we have to also remember, that every device that proclaims any measurement as normal or abnormal has to have a age-matched normative database. And it is surprising to even imagine that a device which has been sold to millions of ophthalmologists, the cirrus, is based on normative database from only 284 healthy individuals. And that database is divided across an age group of 18 to 84 years. If you subtract 18 from 84, what is the number? Simran? 84 minus 18 is?
62 patients.
No, 84 minus 18 is 62.
62 years, sir.
Yeah. And Ankit, 284 divided by 62 is?
Approximately 4.
So at, say, a 46-year-old patient, when they are looking at their normative database, it is based on only 4 patients. And if you look at the next line, you will realize that if that patient is African, the chances of him finding a normative database is compared to only one another person, right? So you have to take the interpretations of OCT with a great pinch of salt. We Indians eat a lot of salt, but when you are interpreting OCT, you have to imagine that you have taking a teaspoonful of salt and gulping it before you are interpreting OCT. Okay, so the diagnosis of glaucoma has to come from OCT with a lot of pinch of salt. And what helps you in interpreting OCT accurately? Gray hairs or lack of hair. Okay, when you have burnt your hands too much, you learn. And my job here is to show you both sides of OCT and where you can really use OCT and where you should be cautioned looking at certain signs. Okay, so this is the typical OCT glaucoma. On the left-hand side of your screens, you're seeing what is called the OCT ONH and RNFL. On the right-hand side, you're seeing what is called the OCT GCL IPL, and that's the ganglion cell analysis, and GCC IPL, sorry. And that is the kind of printout that you will be looking at most commonly. Is there someone whose mic is on and are we hearing some background noise? अंकित भाई तेरा ही सिर्फ माइक ऑन है, ठीक है? I'll point out to you and very frequently when you both need to switch on your mics, and at the same time I will request Simran to switch on your camera. Hot seat is not called hot seat for no reason. Okay, so 3 of us at least have to be present all the time. Okay, let's look at how a typical printout of OCT looks like. And believe me, when you are appearing in your exams and you only describe what each section is called, if the examiner has allocated 10 marks to it, you would have scored 5 marks. And in the real life, you definitely need to know what each of these sections is called, right? Just like visual fields, the top section has got patient details. The map that you see here, and I don't know, I have been a PG DNB examiner for many years. And when I give this printout to someone, I ask them, what is this section called? They freeze. They are not able to say anything most of the times, despite the fact that the name is written here itself. It's the RNFL thickness map. So you have to keep your cool, okay, and hit the ball or try to hit the ball out of the ground. Look, if you are not going to say anything, you are out already. But if you are able to read from the medication pack that you have been given that this is atropine sulfate 1%, right? If you keep your cool that much, you will score that basic marks that is supposed to be attributed to that. Okay. And then this is the RNFL deviation map. Okay. How will you differentiate if you still get confused? Lot of colors is C. And what investigation starts with C? CT scan. So color means it's the thickness map. Okay. And the dull map is the deviation map. Color means CT scan, thickness map. Dullness means deviation map. Okay. But the most important part of the OCT, this is a favorite examiner question, and they will always ask you, what is the most important thing in this printout? And you will automatically say the clock hour and quadrant maps, right? That is where our eyes go. And that is where my eyes went for a long time. But you have to say, no, sir, no, madam. It is the tomograms that our eyes have to go to. And we are not even supposed to look at these on the printout. We are supposed to go to the instrument, enlarge these, zoom on these, and see if the red and the purple line, you can't even see this on the printout, even if after I have zoomed in. They actually delineate the levels. Okay, you can see it on the macular program here, and that there is a reason why it is not there available there on the disc demarcation. So the red and the purple lines have actually demarcated the layers that they have supposed to demarcate. Now, signal strength tells you whether the light is reaching the disc or not. Okay, that's the most important thing. That has to be more than 7 before you can pick up the OCT and interpret. But if you see a disc demarcation where you cannot see the purple line, which basically means the machine has not been able to demarcate the two layers, you are supposed to throw it away. So the most important part of this OCT printout is the tomogram, and that you don't even have to look on the printout. You have to go to the machine and look at it, or rely on the technician who has measured this and then look at it. Then you have the quadrant and clock hour maps, which are very important. Then you have the Tisnit graph for RNFL and the neuroretinal rim thickness. And then you have the summary table. Unfortunately, most clinicians look at first the quadrant and clock hour maps and then the summary table. These are the least important parts of it. They're important for a certain reason, which I will come through you through a certain example. Now, Simran,
Yes.
if you have listened to me,
Yes.
what is the first section on this GCA analysis map? What is this section?
Sir, this is thickness map.
Absolutely great. Ankit, what is the next section that you're seeing?
So this is the deviation map.
Excellent. Simran, what is this that you're seeing?
Sir, tomographs of the
Absolutely
region.
correct. So these are the tomograms. And Ankit, what are these?
Sir, these are quadrant maps.
देखो, आंखें खुली रखना. What is written here?
Sectors.
क्या लिखा है भैया? चंडीगढ़ तुम्हारे पास है, मेरे पास तो है नहीं. Sector maps.
Sector maps.
Right? And this is the summary table. So within 5 minutes, you have been able to learn it. Because when you repeat something, you become masters of it. So every time you go to a class, you learn something, you have to go back and revise immediately, which does what? Puts certain facts in your memory palace. And if you make that part or that thing a familiar part of your memory palace, you can access it anytime, just like Sherlock Holmes. Who is the author of Sherlock Holmes?
David.
Are other people able to speak or type in the chat box?
No,
Arthur Conan Doyle.
other people can stop you and they can even talk.
Oh, really?
Yes, they want, they can unmute their mic and they can talk. There's no problem.
Amazing. Who is the author of the original series of books on Sherlock Holmes? Anyone who wants to type there?
So I think we have two answers from Dr. Madhur and Dr. Hargovind. It's Arthur Conan Doyle.
Absolutely. And because Dr. Madhur has answered partially, I will skip him and go to Dr. Hari Govind. Hari, what is the relation between Arthur Conan Doyle and ophthalmology? You can speak also, right? I'm assuming you have the permission to speak.
Sir, I don't know, sir.
Okay, you don't know. Sir, Arthur Conan Doyle was an ophthalmologist. So, an ophthalmologist lies behind the greatest detective stories published. And who has directed the Sherlock Holmes movies, which featured the modern day Iron Man? Guy Ritchie. Okay. So when an ophthalmologist believes that he is open to collaboration, he can create a lot of money. Okay. And anyway, ophthalmologists earn a lot of money when they're not in a job like me. Right. So coming back to the seriousness of the things here, Dr. Ankur, please let me know when I need to stop, because I tend to just go on and on. And any resident can please also.
We can go on till I think 8:30 very comfortably.
Okay.
Before they start having hunger pangs.
Right. I've also just stepped in from my work, so I'm also hungry. Okay, just let us look at an example, okay? And I will have to speed up myself. I had assumed that you will be pretty good at disc examination. I will assign the right eye disc to Ankit and left eye disc to Simran. Ankit, what is it that you see here that is wrong with the right eye optic disc? I have zoomed it in for you.
Sir, in the fundus photograph.
अच्छा देखो भाई, मैं साउथ से हूँ. I am a North Indian or East Indian, but I have lived in South Indian enough and in LVPI enough कि अगर तुम मुझे सर बोलोगे तो मैं तुम्हें अंकित मैडम बोलूंगा, और सिमरन, if you call me sir, I will call you Simran sir. Okay, so I'm SD. ठीक है? तो Ankit, what is it that you see here?
There is a 0.8 to 0.9 disc cupping with nasal shifting of the blood vessels, and there is a tortuosity of the blood vessels. Along with this, there is an inferior RNFL thinning.
Excellent. It is not called thinning. What you are calling as thinning is a NFL defect, wedge-shaped NFL defect. Right? Yeah, it's a wedge-shaped RNFL defect. Okay. Now, in a normal eye, you should see what you are seeing partially here. Not okay. This area that you see superiorly and inferiorly, they should be the brightest. ऐसा लगना चाहिए कि मैक्युला जो है वो डार्क है. ओके, डार्कनेस में आपका उजाला है. So this superior temporal and inferior temporal area, they should look bright and macula should look dark. Okay, and that is how you figured out that this is dark. Ab Ankit, look at the superior area. Do you think this is brighter than the macula?
Yes, sir. This is brighter.
ये एरिया को देखो.
Sir, compared to macula, it is still brighter.
ए बाबा, ये ब्राइट है. इसके कंपैरिजन में ये डार्क है ना?
जी सर.
है ना? अपन इतना वीटिश, मीडियम फेयर, लाइटली फेयर और फेयरेस्ट ऑफ फेयर बात करते हैं. हाँ, दिस इज डार्कर देन द मैक्युला, एंड यू कैन इवन पिन पॉइंट वेयर इट इज बिकमिंग डार्कर. Right? So this area is also darker. There is a nerve fiber layer thinning superiorly also. Okay. And do you see any changes in the neuroretinal rim?
Sir, there is a temporal nasal thinning.
Okay, which is not relevant to glaucoma.
Not relevant
Now
to
I will request you to do one thing. फ्री में तो अपन लंगर खाते हैं ना कितना, आई डोंट नो व्हाट अबाउट यू, बट बहुत लंगर खाए मैंने, क्योंकि फ्री में मिल रहा था, और लंगर का तो स्वाद ही अलग होता है. फ्री में ऑफ्थेल्मोलॉजी में you get a much lesser than what other specialties get, but you get what is called preferred practice pattern. Okay, and the preferred practice pattern will tell you that one, cupping, two, the vascular signs have no place in diagnosis of glaucoma. The 8 things which are supposed to help you diagnose glaucoma does not include a single vascular sign, does not include cupping, right? तो आईओपी जो शकुनी मामा आग लगा रहा है ग्लोकोमा डायग्नोसिस में, उसका दुर्योधन भाई इज कपिंग. You are not supposed to look at cupping. Okay, I will refine it. You are supposed to look at cupping, but not in isolation, in conjunction with the disc size. Simran, the left eye disc is similar size, larger or smaller than the right eye?
Sir, a bit smaller than the right eye.
Excellent, excellent. And this is the precision that you need to pick up when you look at the two discs separately. You have to acquire the skill of imprinting the images that you see in one eye and then keeping a memory of it and then look at the other eye. And that will tell you that the left eye is smaller. Now, what do you think, madam, of the nerve fiber layer in this eye? Is the superior nerve fiber layer normal or not?
Sir, we can see that there
If
is
you
an
call me
inferior...
sir, I will call you Simran sir.
Sorry,
I've
we
asked
can...
you a specific question. Is the superior nerve fiber layer normal?
It appears normal to...
Excellent. Does the inferior nerve fiber layer look normal?
No, sir, there is an RNFL defect with an
Simran
inferior...
sir, you keep calling me sir, I will also keep calling you sir.
Sorry. We can, I can see a RNFL defect with an inferior notch in the cup.
Excellent, excellent. So there is a wide nerve fiber layer defect here. The superior margin of which you can see and the inferior margin is indiscernible. And does the superior margin correlate or coincide with the beginning of the notch here?
Yes.
Yes, it does. And where does the notch end? Here, yes or no? This is the beginning. Does it end here, yes or no?
Maybe.
Hey, come on. Does it end here, yes or no?
Yes, sir. Yes, sir.
Right. Yes, Simran sir, you are absolutely right. Okay. So if you can see within this wide nerve fiber layer defect, this end of the notch is coinciding with the end of the deeper nerve fiber layer defect here. The darkness of this area is slightly better than darkness of this area. And this is where it is ending. Okay. So I spent this time because I had not included anything else on the disc examination because I had assumed different things. Ankit.
So just one question, please.
Yeah,
Sir,
if you call me sir, I will start calling you madam.
Sir, in Rajasthan, there is a culture.
भाई तुम राजस्थान में नहीं हो, तुम वर्चुअल दुनिया में हो. हाँ, अभी अमेरिकन से बात करोगे ना तुम, तो इफ यू कॉल प्रदीप रामुलू, डॉक्टर रामुलू, he will not even talk to you. You have to call him प्रदीप. ठीक है? तो एक स्टेप आगे छोड़ो एंड बोलो.
सर वो मतलब इसको सर इंफीरियर आरएनएफएल डिफेक्ट ही बोलेंगे, क्योंकि फंडस में तो अपोजिट ही होता है ना जैसे
फंडस में क्या ऑपोजिट होता है?
सर इफ इट इज इंफीरियर वी कैन शो इन द इनडायरेक्ट ऑप्थेल्मोस्कोपी, तो इसको सुपीरियर नहीं बोलेंगे क्या सर?
अरे भाई, ये तो फोटो देख रहे हो तुम, ये इनडायरेक्ट ऑप्थेल्मोस्कोपी थोड़ी है। दिस इज अ फोटो इन अ डिस्क फोटो। दिस इज सुपीरियर, दिस इज इंफीरियर, दिस इज टेम्पोरल, दिस इज नेजल। Okay, when you go from a disc examination to this will appear superior to you, and that is why you're supposed to change. Okay, but this is a disc photograph, and disc photograph is presented to you in proper orientation. Okay, okay. Now,
There's one
Ankit,
question.
again
There's one question, Dr. Siddharth. It says, how
Yeah.
do you diagnose RNFL changes and progression in myopic eyes? This is from Dr. Anirudh Soni. So,
we had a
RNFL,
fellow called Anirudh Soni. And Anirudh, if you are the same person, you are creating more trouble for me. Myopia and glaucoma is another webinar. Let us leave that to a later discussion. It's a higher level. ठीक है? अभी we are at level 1 and let us go to level 2 after this. Okay, myopic fundus, it is very, very difficult to comment on the retinal nerve fiber layer defects because, okay, let me just go into a slightly greater detail. What is shining here? Where is this color coming from? When you see at the papillomacular bundle and you say that deficiency is causing a greater red or orange glow, right? What do you think is the orange color coming from? It is coming from the choroid, right? And the nerve fiber layer is an obstruction. So that is why it looks less orange, and the area where the nerve fiber layer is deficient, it looks more orange. Okay. But when the choroid itself is so deficient, as you would see in a myope, how much impact between, if you have seen the Fair and Lovely ad, there are 10 shades, right? Between the first and the second shade, how much can you differentiate when the choroid itself doesn't have a good glow? That is why the RNFL can create much lesser of an impact on the RNFL related glow of the choroid. Okay, let's go on to the next thing. Ankit, you diagnosed inferior RNFL thinning here, right? Okay. Simran, you decided that there was an inferior RNFL defect here, much wider than what you saw here, right?
Yes.
थोड़ा सा इधर मुझे डाउट था, अंकित को नहीं था. Okay, Ankit, what is it that you are expecting in the visual field?
Dr. Siddharth, there will be if there is inferior RNFL defect, so
I'm sorry, I'll have to step out for a moment, but please continue.
If there is inferior RNFL defect, there should be superiorly, that's the oppositely mirror image in the visual field.
Excellent. And Simran, I thought there was something wrong.
Sorry, sir, your voice is not audible.
Okay. I thought there was something wrong.
Sorry, the voice is not audible.
Is it audible now?
Sorry,
No.
your voice is echoing, sir.
Okay, just give me a second.
no, yeah, well, I think whenever we see the nerve fiber defects in any of the quadrants, the visual field defect will show in the opposite quadrant. And we all know that the glaucomatous visual field defect will kind of honor the horizontal raphe. So if it's an inferior nerve fiber layer defect, you're going to see a superior scotoma. So I just took over Dr. Siddharth because your voice was inaudible to them.
Thank you,
So
thank you,
yes,
thank
yeah.
you so much. And is the superior hemifield completely normal? फंस गया भैया अंकित. Is it completely normal or you see something?
Sir, there is
देखो भैया अंकित, ये क्लास में तुम्हें छुड़ा के रहूंगा. सर जब तक बोलोगे तो अंकित मैडम बोलूंगा मैं.
Dr. Siddharth, it is complete bit of I can see some amount of paracentral scotoma.
ये नेजल है, ये आर्क्यूएट है. ठीक है, पैरासेंट्रल तो ये होगा. ठीक है, सो यू सी सुपीरियर हेमीफील्ड एबनॉर्मैलिटी. इंफीरियर हेमीफील्ड इज लार्जली नॉर्मल. पेरिफेरल पॉइंट्स को छोड़ दो. ओके, नाउ सिमरन, you
Yes.
saw inferior NFL problem, inferior rim problem, superior field correlates.
Yes, sir.
तुम सर बोलोगे तो मैं तुम्हें सर बोलूंगा. सिमरन
Yes.
सर,
Yes.
you saw the superior NFL, superior NRR normal. So Simran sir, is this completely normal?
It is correlating with what we saw
Is
in
it
the.
completely normal? Yes or no?
It is seen in glaucoma cases.
Oh, Baba, I'm asking you yes or no.
Normal as in normal in the patients or in some.
This inferior hemifield on the visual field
Okay.
printout is completely normal or not normal?
I think it is.
You skipped these points, right? And I have specifically chosen this visual field, okay? Because you can see how grossly abnormal this was on the first go. And how much better it has become with one repetition. Okay? You see that. So don't go by just one hemifield, one visual field, and start thinking, ki, oh my God, there is so much glaucoma, there is something wrong in what I have seen on the disc, and the visual field is so abnormal. Okay? Dr. Ankur, I'm going to need 3 more classes. I'm really sorry. I will try to hasten up now. Okay. So when you saw, Ankit, the right inferotemporal hemifield, the inferotemporal NFL as abnormal, do you think this is abnormal? Okay, let me be practical here. I have absolutely messed it up, and I'm going to probably go through only 1 or 2 examples, but I really like the pace of it. I will finish as much as I can, but I will go in the natural flow. Okay. And if you want me to join me for another week, another month, I'm very happy to do that. But let us just sort it out with Ankit and Simran. Ankit madam and Simran sir. Okay. So, which of the rims in the inferotemporal in the right and left eye look the most normal? Which was the most normal NFL that you saw? Left eye superotemporal, right? And you see on the thickness map, you are seeing fire here. What are ganglions or cells supposed to do? The moment the light falls on it, they are supposed to fire a signal to the brain. So on the thickness map, you get reassured about सब ठीक है, सब ठीक है, ठीक है? So in the thickness map, you are supposed to see fire. The left eye superior NFL was the most normal, and that is why you see the most fire here, followed by the right eye superotemporal, followed by the left eye inferotemporal, followed by the right eye inferotemporal, followed by left inferotemporal. ये कैसे समझ में आ रहा है? क्योंकि the greater fire you have, the more red, orange and yellow you will see. Okay? Even if I have to give you one message out of this class, I will tell you that on the thickness map, the more fire you see, उसका मतलब उतना ठीक है. the left eye supertemporal is the thickest, followed by the right eye supertemporal, followed by left eye inferotemporal, sorry, right eye inferotemporal, and followed by the left eye inferotemporal. Jitna blue and black hua, you see this scale, right? Utna gadbad hai. Exactly opposite is the deviation map. है ना? डेविएशन मैप पे इसके कितना ढीला है, इतना ठीक है, इतना ढीला है. Okay, so if you see a lot of red here on the ढीलानेस map, that means that the left eye inferotemporal is the worst, followed by right eye inferotemporal, and then ढीलानेस में there is not much of a difference between the right and left eye superotemporal areas. Okay, is this reflected in the quadrant map? Yes, the same quadrants that you consider abnormal in the right and left eye is abnormal here. But surprise, surprise. Okay, the measurement is not very different. You see, it is 83, it is 83. Whereas the thickness map and the deviation map both clearly tell you that the left eye is worse than the right eye. Have I lost connection? Okay. Now, here is where the law of averaging comes in. Okay. And you will see a great example of this. Look at this. 47. Look at this. 83. Grossly abnormal. Thoda sa abnormal. 82. Thoda abnormal. 92. Completely normal. When you mix it in a quadrant from clock hour, this becomes an average of 47, 82, 80. This becomes an average of 74, 92, 83. So they appear as equal. And that is why clock hour maps are better, because of what is called the law of averaging. ये टर्म यूज कर दोगे ना एग्जामिनर के सामने, they will not ask the questions further. Law of averaging 47, 82, 80 is the same as 74, 92, 83. Okay, so law of averaging is playing out here. But the Tisnit maps, which is the USP of OCT, is showing you the right eye measurements as a solid line and the left eye measurements as dotted lines. Now let us look at the RNFL thickness. Everything that is in green is good. Green is good. Nasal, we don't think of nasal when you're talking about glaucoma. Don't think of temporal when you're talking about glaucoma. Only look at the superior and the inferior measurements. Now, as you both had decided and concluded that the left eye has more damage, especially when it came to RNFL thickness, does the Tisnit curve, temporal, superior, nasal, inferior, temporal, Tisnit curve, correlate with what Simran sir said? Okay, you're nodding. I will go ahead. And Ankit madam, again, Tisnit curve, is it correlating with what you had said?
Yes, Dr. Siddharth, it is correlating with the fundus.
Absolutely. So this is a perfect OCT that you are seeing here. And the same thing is reflected in the
Summary map.
Summary map. Now, the difference between the two eyes, inferotemporal limb, was significant. Fast. The change that you saw between 3 clock hours versus 1 quadrant was very significant. So, the change between the whole average, right, 12 clock hours, 4 quadrants, is going to be even more significant, and that is why localized changes are not going to reflect when you are looking at the average RNFL thickness. It's going to appear just mildly different, and that is what you see here. Okay, so the tendency to start with the quadrant maps first, clock hour maps first, and then the summary maps next is very dangerous. It can lead you to wrong interpretations. And when we looked at the disc size, the disc area of the right eye was larger than the left eye, and that exactly is reflected here also. Okay, and this is the most disastrous class that Dr. Ankur has had. But I have been able to go exactly through 1/20th of my presentation.
Like
How
Dr. Siddharth,
pardonable it
it
is.
has been really interesting the way you have been communicating to people. I think they are having a good frequency to get into their cortex directly, it seems. There are a few statements here, like there's a statement by Dr. Sandeep. He says, we have to have defects in the 3 consecutive visual fields to say it is a visual field defect. So would you like to correct that it is 3 or it is, any other figure, or is it repeatable?
Yeah, absolutely.
And
yeah.
yeah. So it has to be a repeatable visual field defect, which is correlating with the disc defect and the OCT, which again we are going to have to label it as glaucomatous. Anirudh is a fellow of LVPI, it seems, and he doesn't want to leave you like this. So he has put up another question to you, that amongst the available OCTs machines, which has the most reliable normative database for RNFL and GCL assessment?
Okay. Yeah, Anirudh, I understood. With the question. I know him well, and very happy to hear from you. Look, me and Ankit have met for the first time. We will form an impression. Nothing in the world is going to stop that from happening. Okay? Me and Dr. Ankur have met a few more times. Lekin, Anirudh, you are married, right? When the girl's family came to you and wanted to be absolutely certain that they are marrying their daughter to a guy who is not the biggest of disasters. इससे ज़्यादा expectation नहीं होता सास ससुर को, ठीक है? तो the level of certainty is different. I am very cool about Ankit and Simran. I am just taking them at their face value. I have a reputation in my mind about Dr. Ankur, the great surgeon and the great teacher that he is. He would have a certain reputation about me, which has been verified about across conferences, across meetings. But your in-laws will go a further, much longer distance. And that is why for statistical analysis, you need to be more certain. And that is why the Anderson-Patella criteria came. That when you are trying to judge a disc or judge a visual field as certain of being glaucoma, you have to follow these 3 strict criteria. And amongst these 3 criteria, there are 11 points, which only one resident appearing for DNB exam has been able to crack over the last 10 years. There is not a single person in the DNB exams that I took, and I have asked this question to everyone. What is the Anderson-Patella criteria? And you only have to remember 11 points that is there in Kansky. And nobody has been able to do it except one person. That person is a glaucoma consultant in LVPI now. So depending on the level of certainty, you need to make a decision. When everything looks to be in favor, everything in life, every person I have met tells me that सिमरन की तो कोई गलत आदतें है ही नहीं. सिमरन को गुस्सा आता ही नहीं है. वो अपना लंच खुद बना के लाती है. उसके हॉस्पिटल में सबसे पहले पहुंचने वाली वही है, सबसे बाद में पहुंच जाने वाली वही है. टीचर्स की फेवरेट वही है, सबसे पॉपुलर वही है. सो व्हेन यू सी अ डिफेक्ट as small as that in the left eye, a correlating change, even if it is not meeting Anderson criteria in the superior hemifield, and an OCT change that is correlating with what you see in the disc, you don't need to repeat a single investigation. In fact, if you would have seen that disc and the visual field alone, or the disc and the OCT alone, that is sufficient enough to diagnose glaucoma. All criteria, all statistical, these things are meant to be for studies and for you to be even more certain. Otherwise, it's just a matter of being more and more certain. So, सिमरन जो है वड्डी चंगी मुंडी है, जिसको शादी करानी है सिमरन के साथ करा. आई एम होप यू आर नॉट मैरिड. Sorry for the joke, but Dr. Ankur, I think this is where, how long can I go?
I think we can go for another 10-15 minutes. What do you say, guys? Ankit and Simran? I think it's really
Yes.
caught up nicely that you guys are, I think I'm enjoying it.
Yes.
Okay.
Okay, great. Then I will quickly wrap up at least one segment of what the printout shows. Okay, so you have looked at this printout, and I will quickly try to go through each of these segments. This is the first zone, which has the patient's details, and you need to ascertain that you're examining the right person first, and the age has entered right, because the age match database is the most important thing. But as far as OCT is concerned, you have to make sure that the signal strength is 7 or better. Otherwise, you can tell anyone in this world, otherwise you throw that OCT. The impact of reliability parameters on visual field is significant, but the impact of reliability parameters on OCT is drastic. You will see an example of that later if I get another class. This is the RNFL thickness map. Thickness मतलब सब ठीक है, आग होना है. Ganglion cells have to be firing. So the maximum fire that you see, yellow and red are the best colors, is for the left eye superior temporal, followed by right eye superior temporal, followed by right eye inferior temporal. एक बार तो ठीक बोला मैंने. Followed by left eye inferior temporal, and followed by the deviation map, मतलब ढीला है, which is exactly in reverse order, which means the left eye inferior temporal is the worst, right eye inferior temporal follows, followed by the right and left eye superior temporal. ठीक है? Okay, and these are the tomograms. I will come back to why you are not seeing a purple line here, but you should be able to look at the red and the purple lines on where they are segmenting the layers, and be able to make out where they have delineated the lines. I will give you this as a homework on where they are supposed to delineate, how you are supposed to interpret this. The most difficult task I am leaving to you as a homework. This is the most important part as far as the summary table is concerned. Red, everybody knows red is abnormal. Okay. So unlike the visual fields, the cutoffs there are 0.5%, 2%, 5%, and 0.5%, 1%, 2%, and 5%. Here the cutoffs are 1%, 5%, and 90%. Okay. So anything that is red falls below the likely measurements that are likely to occur in less than 1% of normal individuals who are age matched. Yellow means these measurements are likely to occur in less than 5% of aged matched normals. Green means these measurements are likely to occur in more than 90% of age-matched individuals. White क्या है? It is supranormal, like you see in white scotomas. It is beyond what even you see in 5% of normal individuals. And gray means, look at this. Gray means this individual is not covered by the normative database. Now discs, you will always find in gray, because disc का कोई normative database नहीं होता है. Every disc size is normal. So disc size or disc area is always in gray. Okay. Very surprising that the most normal criteria is in gray and not in green. Okay. But then look at this. Any disc area which is larger than 2.5 millimeter square or smaller than 1.33 square millimeter, there the normative database does not exist. The moment you see gray there, and because of this, just throw the OCT printout. Okay? And despite all of these, remember three things. One, that for a 46-year-old person, there are only 4 age-matched individuals that they are comparing your results to. And if you are unlucky and you become an Asian, Asians in America is always Chinese. You are an Indian. So your normative database match is even lesser. And that is why OCT is not a very good instrument to diagnose glaucoma. All your belief, all the things that you have heard till now is myth. OCT is not a good investigation to diagnose glaucoma. It's the best investigation to diagnose glaucoma progression because its measurements are solid. It's not a very good investigation to diagnose glaucoma. All those who are present here, I believe, thoda Zoom pe jaake dekhta hu main, 41 people are attending. You will always remember that OCT is not a very good instrument to diagnose glaucoma, so don't be misled by it. If you become good enough, if you can see the disc the way that you are seeing a disc here, the way Ankit madam and Simran sir looked at it, you are better than OCT. And it is your responsibility to become better than OCT. Okay? I will stop here. I don't want to take too much time, even if I impart very little knowledge. Dr. Ankur, I'll be happy to take any session, any number of sessions you want. But I'm an emotional person. I just went with the emotion. And ये दोनों इतने प्यारे लोगों को आपने सामने रख दिया है that I just kept interacting with them. And I hope I was able to impart some knowledge and understanding to the people I was interacting with.
Dr. Siddharth, it was a really nice way of, I think, presenting a difficult situation, difficult topic, because the disc assessment is the one which we all stress is the core of, glaucoma diagnosis. And you are very rightly said that you should be smart enough than the machines to pick up the things, because machines sometimes can falter and land you into a trap where you can actually miscalculate or misfire your clinical judgment. So I think that's the very good thing Dr. Siddharth has clearly said, that OCT is not a tool to diagnose glaucoma, which is unfortunately, kind of being used as an important tool to diagnose glaucoma. But yes, progression we can pick up on OCT. So I think the class is, I think, very well taken, sir. And I'll not call sir now. I'll call you Siddharth, Dr. Siddharth. So otherwise I will be called as Ankur Madam. So it's very nice to have such clarity of thoughts, and I think everybody took them up well. We'll have you back again for part 2 of this class, so that this finishes off with the good amount of OCT understanding and the correlation with the disc, because this is what is I felt is an important thing people should know of. And can we have a question for the quiz, because that's one point we always
Okay.
kind of. So this will be a question by Dr. Siddharth, and the first two people who would type on the chat box would receive a kind of prize for this quiz.
Okay. I'll just stop sharing my PowerPoint. And I had actually prepared a quiz question which was supposed to come much later in the session, but I'll just share. And here it is. What is abnormal here? Superior nerve fiber layer defect, in superior nerve fiber layer, inferior nerve fiber layer, superior neuroretinal rim plus the nerve fiber layer, inferior neuroretinal rim plus the nerve fiber layer. Let's see who is getting it right.
So you have to answer 1, 2, 3, 4, right?
Yeah.
Sir, 4.
Okay. I think we have a lot of correct answers, and I think Alka Pandey gets the prize here.
Yeah.
Because the inferior nerve fiber layer as well as the neuroretinal rim. Alka, can you unmute yourself?
Yeah, sure.
Yeah. And what is it that is the abnormality here? I will just zoom in onto this here.
There is a notch
Excellent.
and there's a inferior wedge defect, large one.
Excellent. And going to the next stage, I'll point out to where the beginning of the the notch is. Is it here? Yes or no?
No.
Here?
Yes.
Excellent. And this coincides with the beginning of the nerve fiber layer defect.
Yes.
But you will see that the nerve fiber layer defect is usually slightly wider than the notch or the neuroretinal rim defect, which basically means that the nerve fiber layer defect has begun earlier than the notch. And where is the end of the notch? Here?
No.
Here?
Slightly below that.
Here?
Yeah. Yes.
Abhi mujhe samjha. You have started being guided by the appearance of the nerve fiber layer defect, right? So
Yes.
do you see a change in the rim here, shape of the rim?
Yes, definitely.
Now the neuroretinal rim is going to be parallel to the margin of the disc. And that is where, if I zoom it further, it is actually not possible to comment purely on the basis of a one-dimensional image. But you should be able to make out that there is some rim here. Look at the distance between the vessel and the margin here.
Yes.
So there is some rim here. So the nerve fiber layer defect starts here or ends here, but the notch is ending here. Okay?
Yeah.
And Alka, I'll put one more question to you because you won the quiz. What are the slit lamp settings to examine the optic nerve head or the disc? When you examine or mention the settings of slit lamp examination techniques, you have to mention 7 things. The illumination, magnification, the brightness, the length and the width of the beam, the angle between the observation and viewing arm, and whether you have used any slit lamp filter or not. So
Yeah.
in these terms,
coaxial, green filter, and not the full length beam. It should be kind of slightly larger than the size of the disc.
okay,
And high mag. At least
Okay.
15x.
Okay. And that is where we all were taught about this wrongly.
Okay.
We all have been taught wrong. There are two distinct conditions in which you are supposed to do disc examination. And the first of it is to examine the disc proper. You are supposed to have a bright illumination around 2 mm beam width, a height, as you said, just larger than the disc. But if you have used a Hack Street slit lamp, okay, and you close your eyes and you move the illumination, you will hear 3 clicks. One click is at the center and the rest of the 2 clicks is at 10 degrees. That is the paraaxial position. If somebody asks you, what is the depth of the foreign body in the cornea, are you going to go coaxial? You are not.
No.
You are going to go paraaxial, because for stereoscopy, you cannot be coaxial. You have to have an angle between the illumination and the observation arm, and that 10-degree click on Hack Street is meant to be for disc examination. You need to be paraaxial for disc examination. You need to have a high magnification. You need to have no filter. The second condition is you need to have a diffuse illumination. You need to have the diffuser on. You need to have a low magnification. And you need to have the green filter on in order to be examining the nerve fiber layer. Unless you do all of these, you have not examined the disc completely. So tomorrow onwards, every patient that you see on the slit lamp, you spend 2 minutes to examine the disc completely, and then you will be as good as this photograph. And I am absolutely certain nobody missed a finding when you saw this photograph. Your examination should be as good as this photograph, and definitely better than OCT.
Thanks, SD.
Yeah. Thank you, Dr. Siddharth, for such a nice and elaborate class. We'll have you back again for the part 2, and if it is required, part 3 also will be open to it. So this is a
Thank you
forum
so
which, so this is a forum where we want the master to interact with all the attendees and attendees to interact with masters. So this actually fulfills the kind of idea with which we came up with this program. So I would also again like to thank everybody in the support team, the Numerotech and everyone, Dr. Ankit and Dr. Simran. And there's one word for Dr. Alka and Dr. Pooja. You need to text me your email IDs and phone numbers so that we can reach out to you to distribute or deliver you the prizes wherever you are, at least in this, country, hopefully. So because we do have sometimes people from outside India who attend, and then that's it. I will see you all back in the next session, which is the 28th season of Kaksha on 14th of August, where we'll be talking about infectious keratitis. And Dr. Vanithi is the master for the next class. Thank you, everyone. Thank you, Dr. Siddharth, once again.
Thank you so much. Thank you, Simran madam. Thank you, Ankit sir. And thank you, Alka madam. And see you, Anirudh.
Yeah. Thank you, everyone. Yeah.